nice presentation, nice introduction, and Dr. Yes, it's fine. Thank you. Ladies and gentlemen, I want first to express my appreciation and thanks to Dr. Saad Mahdi and the organizers for Mega Course for this great organization and this successful course indeed. And during the upcoming minutes, I'll talk about enhanced recovery after cardiac surgery. I want to draw your attention. If you have any question, you can type your questions in the question and answer area. Also, there will be polls included during the talk, so you need to click to vote on these polls to share your experience. First, I disclose I received the free airway device samples from AMBO and AirTrack in 2014 and 2015 for use in 3 published studies. I have no financial interest with AMBO, AirTrack, or any other industry in the context of this talk or my studies. The first poll, Dr. Saad, have you ever provided care for patients undergoing cardiac surgery? Are you providing care for cardiac surgery, anesthesia for cardiac surgery? Yes, no, I don't know. You can click on your vote, please.
Okay. We'll share now.
Yeah, please.
Okay.
Interesting. We have 63% of voters are practicing cardiac anesthesia, which is very interesting indeed. And we have the other respondents, 36% are not practicing cardiac anesthesia. However, I think it is a good opportunity to know about cardiac anesthesia during this very interesting course after the previous 2 very interesting and informative talks and discussions. The objective of this talk, I'll address what we mean by ERAS, enhanced recovery after surgery, ERAS in thoracic surgery as an example, and how far we have come regarding cardiac surgery, the potential benefits from enhanced recovery after cardiac surgery, protocols for enhanced recovery after cardiac surgery, and where does evidence stand for these protocols, and what will happen in the present and future during COVID pandemic. What does ERAS stand for? Enhanced recovery after surgery. It is an evidence-based care improvement process. So this should be evidence-based. It is provided for surgical patients that could get benefit from and measure improvement in clinical outcomes, as well as reducing the cost of healthcare services. The concept of ERAS has arisen about 2 decades ago in order to achieve a better prognosis in patients undergoing general surgical procedures. The second poll, Dr. Saad, do you have an implemented protocol for enhanced recovery after any type of surgery, not cardiac surgery, for any other type of surgery, for gynecological, oncological, thoracic, urology? Yes, no, I don't know. You can click on your vote, please.
We have it now.
It's very interesting indeed to find 60% of respondents have unimplemented protocols for enhanced recovery after surgery. It's very interesting. The second poll, the third poll, do you have an implemented protocol for enhanced recovery after cardiac surgery? If you are practicing cardiac surgery at your hospital? Yes, no, I don't know. That's also very interesting to find 1/3 of respondents have unimplemented protocol for enhanced recovery after cardiac surgery. because as I'll show you, this enhanced recovery protocols after cardiac surgery started just in 2017. So to have 1/3 of respondents have unimplemented protocols, it's a very interesting thing. I'll move now to, is it time to change our practice if we are not practicing enhanced recovery after cardiac surgery? Actually, yes, it is a change ahead and it is time of changing. There are a lot of editorials and review articles about it is a time to change to enhanced recovery after surgery. And this is one of the earliest implemented suggested protocols. And you can see all of protocols are based on preparing and optimizing conditions of patients starting from pre-operative period, and you will continue this during interoperative and extended to post-operative periods. So what the other specialties are doing now? If you look for the close subspecialty to cardiac anesthesia, which is thoracic anesthesia, this is an interesting study for economic impact for enhanced recovery pathway after lung resection for lung cancer. And this is enhanced protocol. This is a small study. It's including about 150 patients or less. And here regarding the economic impact, I want you to focus on this. You can see we have a reduced operative room cost here. We have a surgical ward stay, there is the reduce of cost, intensive care stay, the cost of drugs for pharmacy, as well as institutional cost for other assisting services, as well as healthcare system cost, and also societal cost. If we calculate this decreases in cost with implementing enhanced recovery after cardiac surgery, you can see in this study there are saving of 12,000 above dollars for care of patients. This is not a small amount, it is a large amount, and it could be invested for caring of other patients. And also for the same protocols for enhanced recovery for lung cancer surgery, the systematic review and meta-analysis, including randomized control studies, they found that overall mortality is favoring lower overall mortality was favoring of enhanced recovery after lung surgery. The mortality is less. Additionally, complications is less, particularly pulmonary postoperative pulmonary complications, which one of the most common night dreams and nightmares for thoracic anesthetists. So the enhanced recovery protocols after thoracic surgery doesn't translated into only the reducing in cost of healthcare, but also extending to improving clinical outcome in terms of lower mortality and lower post-operative pulmonary complications. How far we have come regarding enhanced recovery after cardiac surgery? We are not too far from thoracic, but we are too far from implementing of ERAS, a concept of ERAS, enhanced recovery after surgery, in 2001. Actually, after there was an inaugural enhanced recovery symposium, which is held in Boston in 2017. And this is a meeting for developing of the Society for Enhanced Recovery after Cardiac Surgery. It was the first interest, gaining interest of different experts. It was in the United States in 2017. This is an interesting study starting before developing of evidence-based protocols. This is a small study, and including two arms to study: arm for enhanced recovery protocols and traditional or conventional approach. The enhanced recovery protocols including robotic totally endoscopic coronary artery bypass graft, and you can see here, which is a more important to look for a clinical outcome, the using of ERAS with the robotic assisted approach associated with decrease the length of ICU stay and hospital stay. You can see the length of ICU stay decreased by 1 day and 4 days for hospital stay, which means a lot of saving in healthcare cost. Someone could claim reducing the hospital stay and the ICU and enhanced protocols could be associated with worsening myocardial function or increasing the risk for myocardial ischemia, particularly with fast track cardiac surgery and so fast or too early extubation of patients. You can look for troponin levels at 6 hours and up to 24 hours after enhanced recovery protocol with robotic approach is significantly less during the 6 hours, and also this is extended to 24 hours after cardiac surgery. However, this is a retrospective study, and as I told you, it is a small study. It is a pre and post study. What are the potential benefits of you implementing or developing protocols for enhanced recovery after cardiac surgery? Enhanced recovery after cardiac surgery could be associated with decreased perioperative stress responses, which is translated into shorter ICU stay, shorter hospital stay, lower post-operative complications in terms of the intensity of post-operative pain, the rate of post-operative infection and wound infection, sternal dehiscence, cardiac events, pneumonia, and even bleeding, cerebrovascular accident, acute kidney injury, and other surgical complications. Also, there are area function recoveries. That's meaning the patient can return to normal and functional status earlier than other patients. This is translated into less cost and improved outcome. We have to ask ourselves, can we do the job? Probably, if we are going to develop protocols for enhanced recovery after cardiac surgery. Interestingly, in last August in 2019 in JAMA, there is published guidelines from Iraq's Society, Enhanced Recovery After Cardiac Surgery Society, about guidelines for perioperative care of cardiac surgery, enhanced recovery after surgery, and this is the society recommendation. As I told you, this protocols based on preoperative, intraoperative, and postoperative period. For before surgery, I'll discuss each items later on in details. Alcohol and smoking cessation, monitoring of hemoglobin A1C, and control the level of diabetes for in case of uncontrolled diabetic status, correction of nutritional deficiency, avoidance of prolonged fasting. You have to minimize the hours of fasting, patient engagement technology, as I'll show to you, rehabilitation. For intraoperative period, routine using of antifibrinolytics, except if it is contraindicated, should be encouraged. Avoidance of hyperthermia after discontinuation of cardiopulmonary bypass, infection reduction bundle, and minimize the risk for mediastinitis, wound infection, sternal dehiscence, and need for resurgery. Optimization of sternal closure, this is very important. Also, after surgery, avoiding of hypothermia after after conclusion of surgery and transferring patient to ICU, monitoring of biomarkers for acute kidney injury to early identifying patient with acute kidney injury and minimize the need for dialysis on the long-term chronic kidney disease, chest drain management, and regular delirium screening at least once per nursing shift. Early extubation, glycemic control should be continued from the preoperative period to post-operative period, as Professor Mohamed Salah had described, using goal-directed therapy, either using any of minimally invasive cardiac output monitoring or just using a simple algorithm with mean arterial blood pressure, central venous pressure, and mixed venous oxygen saturation, multimodal analgesia, and thromboprophylaxis. We have to look for the levels of evidence and the level of recommendations for these recommendations. You can see here the highest recommendation, which is class 1 and level of evidence of A, tranexamic acid or epsom aminocaproic acid is recommended during on-pump cardiac surgical procedures. It should be used routinely in all patients except of contraindications. The most common contraindications if you have a patient with uncontrolled seizures, convulsions, or patients with high risk for CVA and stenosis or stenotic lesions and carotids. The level 1 also based on randomized controlled studies, more than one study, perioperative glycemic control is recommended. So it is also high evidence. Adapting a care bundle for evidence-based best practice to reduce surgical site infection, starting from the removing of hair as close as time of surgery, washing of skin with chloroxetine soap, and administering prophylactic antibiotic within 30 minutes from insertion of central line and skin incision. This is high level, also based on randomized studies. Goal-directed therapy, as described by Professor Maged Salah, is recommended to reduce post-operative complication. There is no restrictive fluid therapy. There is no liberal fluid therapy during cardiac surgery. Also, a high level, which is a level 1 evidence, but based on non-randomized study or small randomized study, is a multimodal opioid sparing approach for pain management. That's meaning you have to use different modes with reducing the opioid use increasingly, but it is not included in the guidelines. There is a effects for using of some regional blocks for post-sternotomy pain. Also, a level 1 evidence, persistent hypothermia after cardiopulmonary bypass should be avoided, at least in the early post-operative period. Also, it is based on non-randomized studies. And also there is here maintenance of chest tube patency. It is a very important and recommended to prevent clotted blood to occluding it. Additionally, maintenance of chest tube post-operative systemic delirium screening using some screening tools. There are several screening tools are available. It should be recommended at least once per nursing shift. That's meaning at least 3 times per day for the first 3 to 4 days after cardiac surgery using cardiopulmonary bypass. The next one is also level 1, which is based on observational studies and low evidence, is smoking and hazardous effects of alcohol use, and should be stopped for weeks if it is applicable. Usually we acknowledge that is not possible for most type of cardiac surgery. Other recommendations with level 2A, including early detection of kidney stress and interventions to avoid acute kidney injury, are recommended following surgery based on randomized studies. Rigid sternal closure using different type of closure techniques, figure 8 plates or others, is useful to improve and accelerate sternal healing and reduce the incidence of dehiscence after cardiac surgery. Also, class 2A, including rehabilitation, is recommended for patients undergoing elective cardiac surgery or multiple comorbidities, or if there is a significant deconditioning. I'll show you later on an examples of rehabilitations. Another one based on non-randomized study, which is level 2A, insulin infusion is recommended to treat hyperglycemia in patients post-operatively. And similarly, strategies to ensure extubation within the first 6 hours after cardiac surgery is highly recommended. There is also level 2A recommendation, but based on observational studies, patient engagement tools, including you can providing for your patients online virtual protocols, educational videos, interviews, and you have to demonstrate the patient's compliance with the regulations after surgery, and the patient reported outcomes which will be improved with this technique. Level 2 also based on observational studies, including chemical thromboprophylaxis against the risk for deep venous thrombosis and pulmonary embolism. Also 2A levels, the operative measurement of hemoglobin A1C is recommended to assess for risk stratification. And the post or pre-operative correction of nutritional deficiency is recommended when feasible, and you have time for this. Less evidence, which is level 2B, including clear liquid should be continued up to 2 to 4 hours before surgery. There is no meaning to ask patient to stay fasting for 8 hours or 10 hours before surgery. Additionally, preoperative carbohydrate loading may be considered up to 2 hours before surgery. Additionally, for this one and level 3, no benefits was shown with stripping or milking of chest tube to remove the clots or to disturb the sterile area of chest tube insertion. There is no benefit from this practice, so we should avoid it. Also, there is a harm which is based on randomized studies, that's meaning strong evidence. Hyperthermia more than 37.9 centigrades during rewarming after cardiopulmonary bypass is potentially harmful and should be avoided. There is an aerial protocol described from this group of investigators 2 years earlier than JAMA paper. And you can see here is including also pre-operative period. They looks like the same recommendation for Iraqi society. However, if you can look here, they added some important items like methicillin-resistant staphylococcus aureus screening, which is a very important, use of antiseptic soap before surgery, oral administration of statins, and we have to look for evidence for this. Also, for day of surgery, it is similar to avoid long fasting, carbohydrate load. However, interestingly here, using anxiolytics to minimize anxiety, and you shouldn't consider using of benzodiazepines and minimize the use of opioids for geriatric patients older than 70 years. For intraoperative period, it is also similar to Iraq's protocol, except of the adding a routine anti-inflammatory therapy, aggressive use of vasoactive medications to avoid hypotension, and then as the risk for post-operative cognitive dysfunction, complications, CVA, and minimally invasive monitoring as described by Professor Mohamed, and using minimal invasive approaches as described by the earlier studies on robotic assisted CABG. For following surgery, it is very similar also to the Iraq's protocol. However, if you take a look here, they included protective ventilation based on driving pressure and using alveolar recruitment strategy or maneuvers, facilitation of gastrointestinal function recovery, including this as recommendations. Next, we have to look where does evidence stand for regarding every one of this recommendation. First, if you take a look here for risk stratification, there is a growing evidence of the efficacy, feasibility, and validity of using Euroscore 2 and also SAPS-3 as predictors for risk stratification before cardiac surgery. So it is very important to calculate Euroscore 2 before going to surgery for your patient. What is the risk stratification? Why risk stratification is important? Because we have some non-modifiable factors. We cannot work with them like age, gender, race, prior myocardial infarction, previous cardiac surgery, emergency surgery, combined procedures, or coronary artery bypass graft for left main coronary artery disease, obesity. We cannot deal with this. However, we have some modifiable factors here on the right side, like uncontrolled congestive heart failure. You have to consider using of diuretics, ACE inhibitors, low dose of beta blockers before surgery to optimize the cardiac function as much possible as you can. Control of uncontrolled diabetes, control uncontrolled hypertension, alleviation of the incidence of chronic kidney disease, management of atherosclerosis and cessation of smoking. And if you have anemic patients, as Professor Samir described, you have to correct it during the pre-operative period and consider blood conserving strategies. So we have to look for other items for recommendation, infection, and outcomes. In this study, including 2,100 patients undergoing coronary artery coronary artery bypass grafting, the secondary is they looking for incidence of surgical site infection, patients who developed 1/3 of the 2/3 of them developed the surgical site infection. More patients who developed skin surgical site infection needed to readmission within 65 days of surgery, 2 times more than patient without surgical site infection. However, interestingly, there is no significant decrease in 65-day mortality among patients with or without secondary surgical site infection, which is interesting. Regarding preoperative nutritional optimization, this is study including 787 patients undergoing valvular, CABG, or combined procedure. And 60% of these patients received artificial nutritional support during the preoperative period. 2/3 to 3/4 of them received enteral nutritional alone. 17% received the combination of enteral and parenteral nutrition, and 5% received parenteral nutritional alone. We have to look into the outcomes of this study. There is increase in energy take, and protein intake is not significant, so with unadjusted and adjusted odds ratio. However, the most important here, post-operative cardiac surgery patient who stayed longer in ICU for 3 days or longer were at high risk for inadequate nutritional therapy. So patients who exhibit or presented with the signs of nutritional deficiency, you have to expect if you are not going to correct this deficiency, the patient might stay longer in ICU. This is a small study indeed, however, it is important primary outcomes, including about 100 patients, and the preoperative malnutrition was identified as a predictor for early post-operative delirium. So malnutrition doesn't translate only in prolonged stay in ICU, but might be translated into more risk for post-operative delirium after on-pump coronary artery bypass graft. Regarding preoperative physical activities, this is a meta-analysis systematic review, including 11 studies and multiple tools to measure physical activity, but they didn't conclude and to do quantitative analysis and meta-analysis. However, later on, and 2 years ago, this is the meta-analysis including 17 randomized controlled trials. 12 of these randomized controlled trials were addressing for post-operative pulmonary complication and included in meta-analysis. 11 studies included for a meta-analysis for the length of stay after cardiac surgery. Interestingly, inspiratory muscle training using this device, you must know this device, this is called inspiratory muscle training incentive spirometry, and patient receiving inspiratory muscle training reduce the risk for post-operative pulmonary complication and also the length for hospital stay, which is a very significant indeed. Regarding preoperative statins, if you remember, this is aerial guidelines, they including routine using of statin therapy, but this wasn't included in the Iraq's guidelines. This is a meta-analysis including 20 studies and more than 3,000 patients who received or didn't receive statin therapy before cardiac surgery. Let's see what will happen for the results. Actually, there is no difference in terms of mortality for low risk of bias trials or even for all trials. There is no difference in the risk of mortality with using or non-using of statins during the preoperative period. More interestingly and worrisome indeed, patients receive statins associated with it wasn't protective first against atrial fibrillation, myocardial infarction, stroke, or infection. However, it is a very worrisome that there is increase of acute kidney injury after preoperative using of statins before cardiopulmonary bypass. Glycemic control. This is a study including 760 patients, and they divide the patients according to the level of hemoglobin A1C, either less than 6.5 or equal or greater than 6.5%. You can see there is no difference in the risk of complications, myocardial infarction, bleeding, deep sternal infection, stroke, pneumonia. renal failure, tamponade, death, or atrial fibrillation. Now, the next poll, Dr. Saab, please. When are patients extubated after cardiac surgery at your institution? If you are practicing cardiac anesthesia, immediately on operating room table. Number two, less than 2 hours from admission to from conclusion of surgery. Number three, 1 to 6 hours, or number four, 6 to 12 hours after surgery. Please click and vote on this about your practice. We have only 10% of respondents are extubating patients on tables. However, the majority of practitioners is about 70%, that's meaning about 2/3 or more than 2/3 of respondents are extubating patients between 1 to 12 hours after surgery. And only 13% are extubating patients before within 2 hours. That's also interesting. If we have another poll, if you are not going to extubate the patient immediately on table after cardiac surgery, are your concerns? It is a major procedure. Cardiac surgery is a major procedure. Number two, risk for hemodynamic instability. Number three, risk for myocardial infarction. Number four, risk for post-operative bleeding. Number five, sternal operating and closure, there may be dehiscence. And number six, need for reintubation, particularly with using high dose of opioids. Number seven, severe post-operative pain. Why you are not extubating patient on table after cardiac surgery? Can you click on your vote? That's very interesting. Half of respondents, they are concerned about the risk of hemodynamic instability. Let's say one of the standard golden criteria for extubating patients after cardiac surgery is in table or in ICU to have a patient with hemodynamic stability on no or low rate of infusion for inotropes and vasopressors. So we are not expecting to extubate patient with hemodynamic instability. Let's see about a major procedure. Okay, cardiac surgery is a major procedure, but what's about thoracic surgery for pneumonectomy? We are extubating patients on table. What's about neurosurgery cases with extensive brain tumor resection from base of the skull lasting for 12 hours or longer? We are extubating patients on table. So major procedure itself doesn't preclude the need for the indication for immediate extubation after cardiac surgery. What's about risk of myocardial infarction? I showed you before the troponin level up to 24 hours after adapting of Iraq's protocol was less than those patients undergoing conventional ventilation and non-Iraq's protocol. So myocardial infarction is not a risk. I'll show you more evidence now. Risk for post-operative bleeding. Okay, this is a good concern, but let's discuss it. If you have a patient after thoracic surgery, after pneumonectomy, and there is disruption of the ligature over the pulmonary vein, and you have horrible bleeding, would the patient would die? No. You are going to intubate the patient, restate the patient, and take the patient back to our. This is the same for cardiac surgery. However, we have a concern and indications against immediate extubation on table for after cardiac surgery if you have a patient with chest tube output more than 50 milliliters during the last 30 minutes during and after conclusion of closure. Sternal opening, you might need to re-explore the patient, and to recrochure, you might concerned about sternal dehiscence. Okay, this is indication to ask the surgeon to do a strong fixation for the sternum. In case of reopening, as I told you, it is not a big issue. Need for intubation and high dose opioid. In Iraqis, there is no more role for high dose of opioids. We're using a very low dose of opioid or opioids with opioid sparing techniques like using of NAMD antagonist, ketamine, magnesium sulfate, or others, combination of non-steroidal non-steroidal anti-inflammatory drugs if it is not contraindicated, or using paracetamols, blocks, local infiltrations. We have different techniques. Same, it could be translated into a better quality of post-operative analgesia. Let's see what will happen here for fast-track cardiac anesthesia with using of short-acting anesthetics, opioids, and so on. It is one of the patients. So you have to choose between sending the patient to ICU, intubated and ventilated on sedations, and you have a longer time, or you have to offer for the patient from the beginning, from your consent, if the patient prefer to talk to family instead of breathing through a tube, which is a priceless. When do you extubate your patient following cardiac surgery? We have to look for evidence. What do we mean by fast-track cardiac anesthesia? Everyone will answer the question. It is 6 hours, within 6 hours after surgery. However, this is a recommendation from the Society of Thoracic Surgery, STS. However, it is a benchmark which is not based on physiological evidence. It is just a consensus agreement. However, later on, in 2017, in this study with pre-protocol and post-protocol of early extubation of cardiac surgery patient, they found that the ventilation hours, of course, is less with early extubation. And interestingly here, ICU hours stay is prolonged after keeping the patient intubated for 12 hours or longer after surgery. So it is not just 6 hours, it may be 12 hours. What's about the risk of 30-day mortality and risk for major complications except of the need for re-intubation? In this another study, they found that a time period of 6 to 12 hours is the cut point for more mortality and more post-operative pulmonary complications. So again, fast-track anesthesia, cardiac anesthesia couldn't be defined as extubation within 6 hours. However, the actual ventilation times that lead to increased complications exceed 12 hours. Okay, let's to see for more recent study in 2018, which is a very strong study indeed, which is STITCH trial. STITCH trial is surgical treatment for ischemic heart failure. And this is a study including 14,000 surgical patients and who survived surgery up to 36 hours after cardiac surgery, CABG surgery. And at 36 hours post-operation, 90% of patients were extubated. However, we have to look here, intubation time was the strongest independent predictor for 30-day mortality and even 1-year mortality. So if you're leaving your patient intubated and ventilated for longer hours, that's meaning you are reducing the chances for this patient to survive, not only at 1 month after surgery, but up to 1 year after surgery. This is another meta-analysis and systematic review, including patients, so 35% of them needing ventilation for greater than 48 hours. There is no difference in mechanical ventilation time of shorter with those extubated area. However, this is very interestingly here to look for this study. Another important outcome is the post-operative delirium. Post-operative delirium increased with each 1 hour increase of intubation. If you're intubating the patient for 1 hour after surgery, there is 1 time increase in risk of delirium. For 2 hours, it will be 2 times. For 10 times, for 10 hours, it will be for 10 times increase in the risk of post-operative delirium, which is very important because It might preclude the protocols for enhanced recovery after cardiac surgery. It might increase the cost of healthcare and increasing the complication, hospital stay, and poor outcome for patients. This is a Cochrane review, including 28 relevant randomized control studies for patients at low or moderate risk of death after adult cardiac surgery. And then 18 studies, they use low-dose opioid anesthesia, and 16 studies used extubating patients within 8 hours. Interestingly here, when we look for early extubation associated with less deaths in ICU, less deaths in hospital after surgery, less deaths of 1 month after surgery, and less deaths regardless the cause. However, compared with low dose opioids and here high dose of opioids, post-operative myocardial infarction, here is a concern, if you remember the polls, about the high incidence of myocardial ischemia is less with low dose of opioids and hence earlier extubation. Stroke is and acute kidney injury, major bleeding, need for intubation is less with using low dose opioids, and which is translated into low time to extubation. We have recently published studies including small cohort of patients, just 73 patients. We were comparing different effect site concentrations of remifentanil. That is not the issue. However, interestingly, we succeeded to extubate 60% of patients on table. The most important clinical impact of this study is not the effect site concentrations, but we succeeded to change our routine practice. The practice at our center to extubate the patient 6 hours longer or to keep the patient ventilated overnight. Here we could succeed to extubate 60% of patients over table. We identify independent predictors for extubation, early extubation in table, including low Euro score and the changes in propofol, cumulative use of opioids, so fentanyl and the propofol. Here we compared the immediately patient, 45 patients immediately extubated in table. This is one of them. This is post hoc analysis, and 26 were received conventional ventilation. We found some differences. Patient with shorter aortic cross clamp time, shorter cardiopulmonary bypass, surgical anesthesia and surgical times, readmised extubation associated with, more of them are associated with immediately are being immediately extubated on table. There is less risk for ischemic events, myocardial ischemic events with immediate extubation, less need for transfusion. It is not much significantly. You can see also we have higher opioid consumption with patient controlled analgesia with morphine, but it is not too much. It's just 4 milligrams. It is not of clinical importance. And interestingly, the hospital stay is reduced by 1 week. You can imagine decrease the cost of healthcare by 1 week. If we look again for other marker for myocardial ischemia, troponin level up to 12 hours after surgery were half of patient were immediately extubated than conventionally one. And the risk of bleeding, also half of them have bleeding than patient received conventional care and post-operative ventilation. Perioperative fluid therapy, I would skip this one because Dr. Mohamed has explained it in details. However, I want you to look for this meta-analysis and systematic review, including 9 studies about the goal-directed fluid therapy associated with shorter hospital stay after cardiac surgery, and overall analysis revealed no significant differences in all-cause mortality, duration of mechanical ventilation, or length of stay. However, there is a shorter hospital stay, but not shorter ICU stay. Protective ventilation, if you remember the other group which implemented the area protocol in 2017, including protective ventilation. This is a systematic review and narrative census, which failed and showed low certainty in evidence with using intraoperative or postoperative protective ventilation approaches in cardiac surgery. Finally, about patient education. This is an example from Papworth Hospital. This is one of protocols to ask the patient to shrug shoulders and then to twist the trunk maximum as he can or she can, and leaning forward, doing inner range, straight leg raising, and middle and inner range. This is the rehabilitation. You have to prepare the patient to move out of bed as early as possible before surgery, which should be started from educating your patient during pre-operative period. Additionally, sit to stand, doing squatting and sit up on a step or standing on heels and in front of feet are strengthening the calf muscles and reduce the incidence of thromboembolism and deep vein thrombosis. And now the question, what will happen in the future? You should know the WHO declared the pandemic for COVID-19 on March 11, 2020. And all scientists are expecting to have a second wave soon in winter. And we are concerned about this. We shouldn't and we cannot, for different economic and ethical issues, to stop elective surgery again. So we have to look if we can extend the using of enhanced recovery protocols after cardiac surgery during COVID pandemic. This is a very interesting review article and published about 20 days ago in Journal of Cardiothoracic and Vascular Anesthesia and Cardiac Surgery and COVID-19 patients. Compete for, as you know, they are competing for resources. So they are demanding for physicians to taking care and nurses to taking care of COVID patients, allied health care services, shortage in ventilators, in ICU bed, and continuous renal replacement therapy or extracorporeal life support, because these items are using for COVID patients. Also, we might have a shortage in medications and nutrition for parenteral or total parenteral nutrition, vasoactive meds, or sedation meds, or blood products even. So we need to look if the protocol for the Society of Enhanced Recovery after Cardiac Surgery could be extended or be helpful for patients with COVID undergoing cardiac surgery, suspected or confirmed COVID. We have to look for, this is the items of including in the enhanced protocol of the Society of Iraqis. You can see about the expected benefit is expected to be high in one of the pre-operative factors, which is using surgical site infection reduction bundle, would be helpful even for COVID patient. Intraoperative multimodal opioid sparing analgesia and hence extubating the patient area, free up the bed of ICU and reduce the need for using of medications, and the light of drug shortage is also could be large benefit getting from COVID patients. Routine administer of intraoperative antifibrinolytics, as I told you, tranexamic acid or epsom aminocaproic acid. There is a large evidence. Maintain intraoperative glucose levels below 180 milligram per deciliter, and this is also extended to the post-operative care. There is a large expected benefit in COVID patients. Also, if we took a look for avoid persistent, avoid hyperthermia and avoid hypothermia, would good benefit also for COVID patients. For post-operative care, again, post-operative multimodal opioid sparing analgesia, optimize strategies to ensure extubation as early as safely possible, and promote early mobilization and removal of chest tube drains, lines, and so on. All of this are expected to get a large benefit for COVID patients. At the end, the conclusion is this talk: enhanced recovery after cardiac surgery is the present and the future revolution in daily practice. We should implementing systematic approach for Iraqis at our centers. If we don't have such protocols, there are several physiological and economic benefits from Iraqs, and the current evidence can support lot of or most of Iraq's recommendations for enhanced recovery protocols. However, we still embed need for more longitudinal, larger studies to test the efficacy of this recommendation on different clinical outcome, like mortality for 1 year or longer, like hospital stay, ICU stay, cost analysis studies, and so on. Thank you so much for your listening, and I welcome your questions.
Okay, we do have a question for Professor Eltahan.
Yes.
The question say regarding early extubation, even if the patient is hemodynamic stable, she's aware about the procedure duration. She said that the drip perfusion is not enough if the operation is more than 6 hours. She had the fear of risk of rebound hypothermia, increased oxygen demand, risk of rebound heparin effect, and consecutive bleeding. All these factors can lead to hemodynamic instability. She's in fear of early extubation in this situation. What's your opinion, Professor Mohamed Tahan?
Okay, thank you for the question. Actually, if we take one point to one point, if we look for a longer time of surgery, the most important predictor for early extubation or immediate extubation is not the duration of surgery itself, but the duration of aortic cross clamp and cardiopulmonary bypass. If you have aortic cross clamp longer than 120 minutes, if you have cardiopulmonary bypass time more than 180 minutes, this precludes the indication for immediate extubation on table. So it is not the whole time of surgery. For example, you have a patient undergoing pneumectomy for 8 hours or for 10 hours sometime, and also you might know about lung transplantation, single lung transplantation. There are many practitioners nowadays are extubating patients on table. So it is not a major issue. Regarding hemodynamic instability, reperfusion time, you have to consider good reperfusion time. You have to judge the patient's conditions, hemodynamic stability, parameters as described by Professor Magid Salah and Professor Samir. And if you are going with any tropes or vasopressors, and you have to judge all of this through multidisciplinary discussion with your surgeon. Regarding rebound hibernization, if we can consider this, if we are using focused monitoring for coagulation, point of care monitoring for coagulation, and if we are going to titrate protamine as much as heparin given, not higher, not lower, we are not expecting to have a rebound hibernization. Rebound hibernization, if it happens and you have medical bleeding, which is not significant, as described by Professor Samir, to less than 400 during the first hour or 200 in the subsequent a couple of hours, this doesn't preclude extubating the patient. So you can correct, and if you have a patient who is already extubated and you don't have high volume of chest tube drainage, you can correcting the medical factors and coagulopathy different factors as described by Professor Samir and the others. Regarding hypothermia, hypothermia, it could be continued, and during transferring the patient, we all know about the physiological draft of half to 1 centigrades after cardiopulmonary bypass. Here you have to stop your cardiopulmonary bypass with a temperature not less than 36.5, and you have to continue warming intraoperatively up to during transferring your patient to CCU, particularly if you are going to extubate the patient with using enforced air mattresses or water mattresses, warming mattresses. Otherwise, you cannot extubate the patient. I think I answered her points.
Thank you, thank you. And the last question for Dr. Tahan also.
Yes,
in the literature, what are the most important monitors used in poor countries which can give you the fast tracking of in those type of patient, I mean in cardiac anesthesia? If I have to get a monitors with little money, which monitors you preferred in the literature which can give you this access?
That is a very important question. I think I answered it during my talk in directly. And Professor Magid demonstrated that the using of the expensive technology of minimally invasive cardiac output monitoring, although I improve for using them, is not the standard of care nowadays. However, not only in low-income countries, I wanted to share with you that most of European countries nowadays are using routinely only arterial line and central venous catheter for a routine monitoring for cardiac surgery, except if we have a complicated cases, if we have lung transplantation, if you have cardiac transplantation, you have to consider using of pulmonary artery catheter. Of course, the indications for transesophageal echo during intraoperative course, there is no doubt about it. And there is a recommendations from different societies about the recommendations, particularly during valve surgery, or as Professor Magid described, in patient with right ventricular dysfunction or difficult weaning of bypass. However, routinely, in routine cases, for a fast track protocols, you can use only arterial line. If you take a look in a mechanically ventilated patient with tidal volume 7 to 8 milliliter per kilogram of tidal volume, and if you take a look for variations in the arterial waveform with the breathing, if you have this accentuated variation, this is indicated for hypovolemia if you are excluding other causes. If you have already low mean arterial blood pressure, as Professor Samir indicated, as I told also, you can take a samples, no need for continuous monitoring, samples from a mixed venous blood from a central line, and according to SSDVE2 as described in the protocol by Professor Magid and Professor Samir, we can judge the need for increasing of fluids or needing for inotropes, and according to hemoglobin level, this is a goal-directed therapy. You can define if you need to give a fluids or transfuse blood. This is in a patient with MAB 65, less than 65 millimeter mercury or less than 20% in hypertensive patients. And then decide to give fluids. If you have low mixed venous oxygen saturation, this is indicator for low cardiac output. And if you have optimized CVB, for example, you have to consider increasing inotropes. If you have normal mixed venous oxygen saturation and still have low mean arterial blood pressure and normal range of central venous pressure, you have to consider using vasopressors at this time. Of course, it is not a situation to talk about mechanical circulatory support, because if you are talking about you don't have the facilities for advanced monitoring, at least, so you don't think you have access for mechanical circulatory support.
Thank you, Professor Eltahan.
Most welcome.
Finally, I have to say thank you very much, Professor Samir Al-Ansari. Thank you very much, Professor Magid Salah. And thank you for my dear colleagues, Professor Mohamed Eltahan. And we have finally to say, we appreciate this mega online course. We have to appreciate and we have to thank Dr. Saad, Dr. Walid, Dr. Hisham. Actually, we get a lot of information. It's amazing, Dr. Saad. Go on, keep on. And my appreciation and for this invitation for this nice night. Thank you very much.
Thank you very much, Professor. We are so honored to have this number of professors tonight, and our guest here, Dr. Yasser Reda, Dr. Adil, and Professor Samir Ansari, Professor Magid Salah, and Professor Mohamed Eltahan, and finally Professor Magdi Atallah. Thank you very much for really successful night tonight. This episode, I think, is episode 40 of the Mega Online course, very successful. Next Sunday at 7 o'clock Cairo time, we have another day. We are looking forward for that day. It is intensive care day. Particularly, we are going to talk about sepsis. 4 eminent speakers about intensive care, and they are going to talk about sepsis and the guidelines and the bundles and the protocols. So keep tuned, keep attended, please, to next Sunday at 7 o'clock Cairo time. From myself and my colleagues, thank you much for being here today, and we are so honored to have this number of people here, this number of attendees, and this amount of support for our course. Thank you.
Thank you.
Thank you, everyone. Thank you, professors.